Right, good afternoon, everybody, and welcome to the Improvement and Innovation Showcase on Workforce Sustainability, Building the Future of Healthcare. My name is Isla Boyd, and I'm the Strategic Lead for Workplace Wellbeing Partnerships here at the CEIH, and it is my pleasure to be hosting the session today. Before I start, I'd like to acknowledge that CEIH is based on the traditional lands for the Kaurna people and that we respect their spiritual relationship with the country. I also acknowledge the Kaurna people as the custodians of the Adelaide region and that their cultural and heritage beliefs are still as important to the living Kaurna people today. I'd also like to extend my acknowledgement to other lands that people may be joining this session from today. Before we start, just a little bit of housekeeping. So this session has been preset to keep your mics on mute and your cameras turned off by default. However, this will be enabled during the Q&A time after today's presentation. And it's only the presentation will be recorded and published. The recording will be stopped for question time a bit later on. So please engage with us then via the Q&A function or use your mics and please feel free to turn on the cameras then. We'd love to see your faces. Finally, before the Q&A, there will be a really quick survey, a poll pop up on your screen to complete. We would really appreciate you just taking a couple of minutes to complete that to help with our evaluation of today's event. So just quickly, for those of you unfamiliar with the Commission on Excellence and Innovation in Health, or CEIH for short, we're the lead agency for innovation and healthcare in South Australia, and we love bringing together consumers, clinicians and other collaborators to turn ideas into better healthcare. So our vision is together creating health and prosperity for all. And to do this, we're supporting the sector to come together to imagine new ideas for better healthcare. And we acknowledge that better isn't always excellent, but we're committed to measuring what we're doing so that we can understand what impact change is having. So the essence of why we host the Improvement Showcase is connecting people in South Australia and across our sector to provide a space to explore what others have learned. So it's about sharing ideas, improvements and innovation. During the series, the recorded sessions are approximately 40 minutes and they'll be made available online following the series. We aim to keep it simple and share work happening across the sector at any stage or level of success. So not just waiting until work is complete or ready to be published. And we try and focus on work in South Australia, but every now and again we do share a showcase from outside our state to ignite some new ideas in South Australia. So just a quick prompt: if you have a problem or you've had success solving a problem, or whether you've learned something or you're trying to do something, or you've if there's anything you'd like to see explored, please get in touch with us via the email displayed on the screen now. We'd love to hear from you if you have something to share. So now it's my time to introduce the theme of our 17th series, which is Workforce Sustainability, Building the Future of Healthcare. This one is a particularly important topic for us here at the CEIH, and as such, it forms one of our core strategic directions. We're committed to putting people at the centre of everything we do, and our workforce is the cornerstone of our healthcare system. Our system relies on a strong and sustainable workforce to deliver safe, high-quality care. So really supporting our workforce is not just critical, it should be foundational to everything we do as a healthcare system. Workforce sustainability is a multifaceted and complex challenge, and as such, we must start thinking differently if we're to keep up with the predicted workforce shortages and increasing demands on our healthcare system. We could have easily included way more than just 4 sessions on this topic, given the breadth of what drives workforce sustainability and the range of initiatives that are underway across South Australia to combat this. But we are excited to showcase a diverse range of initiatives over the series, which started last week, from across Australia. So each approaching workforce sustainability from a different angle, from work redesign to models of care, to recruitment pipelines, through to embracing our intergenerational workforce. So if you haven't registered for the 2 other episodes in this series, we invite you to do so via the QR code at the bottom right, which will link you directly to our registration page. So I'd like to introduce today's speaker. So Naomi Burgess is the SA Health Chief Pharmacist. Naomi's role as Chief Pharmacist provides expert advice, leadership and strategic direction in regards to statewide legislation, policy and programs for pharmacy, medicines and health technologies to ensure the best possible health outcomes for all Australians. In recent times, Naomi's work has focused on developing and implementing system-wide strategies to support sustainability of the health system through strategies such as expanding the scope of practice for community pharmacists and supporting the ongoing development of the Community Pharmacy Expanded Scope of Practice initiative, where pharmacists with additional training offer consultations to assess, manage and treat a range of conditions. Thank you, Naomi, for joining us, and I will now hand over to you.
Thanks, Isla, for that introduction, and thank you to the Commission for inviting me to come along and share some of our experiences and work today on this very important topic close to all of our hearts, sustaining our workforce and sustaining our health system really through that workforce. So today what I'm going to talk about is particular focus on community pharmacy services as one example of how we have looked to broaden scope of practice to support and develop and really collaborate across settings in regard health service provision and workforce sustainability. So I have got a slide today that I feel like I'm probably preaching to the converted here, but obviously it's well known that we've got increasing need in our health system, increasing demand for many reasons around the ageing population, chronic conditions, increased complexity of those conditions and the treatments that are available, and also costs increasing. And that's leading to pressure on our health system across the board, in primary care, in our public hospitals and aged care and other settings as well. So it's, it's upon us all to work together to take these things forward. In there, we've also got obviously workforce impacts, and I've just put a couple of examples there that we know, for example, around the GP workforce, there's some challenges there predicted over the coming years, and there is challenges there at the moment, as there is across other workforces as well. We've also got that challenge of consumer access and healthcare provision in geographical areas, broadening our service hours of care as well, so after hours care, 24-hour care, as well as affordability for consumers, affordability across the system for us to have those services available, and also things like reduced bulk billing being an example of impact there. So nationally, there's been multiple reviews now over many years, and I've listed just a couple there and some pictures there as well. So, for example, the Productivity Commission 5-year inquiry, which I reported in 2023, found that using health professionals, including pharmacists and others, to their full scope of practice is an effective and an efficient way to improve access to healthcare in Australia. In addition, the report that came out just late last year, the Scope of Practice Review, also highlighted using innovative models of care, and many aspects of that were included. And I've just highlighted their health practitioner roles and the need to innovate and optimise how we use the expertise we've got in our very broad healthcare workforce, which doesn't limit to hospital care, doesn't limit to medical care, medical practitioners. It's that broader group of allied health and all the different health professions that we have available to us, being a focus of this work as well. And we're certainly taking forward some of that work here in South Australia and those recommendations. But today I was going to talk just about the local work, and as I said, I'm using an example of urinary tract infection as work we've done over the last couple of years in this space. So just a bit of background about urinary tract infections. So these are one of the most common conditions experienced in our community, in being in the top 20 reasons to visit a general practitioner for advice and treatment, with 1 in 3 women experiencing them, and up to 50% of women experiencing at least one UTI in their lifetime. So it's very common. In men, much less common and usually more complicated just because of different presentation in men as well. So today I'm just talking about treatment in women. But of course, if you've ever had a urinary tract infection, quite a lot of discomfort, pain, really you're unable to probably work or to work effectively, and people do report an impact on how they can manage their lives and family time. And of course, if untreated, some of these, a small number, but still some, can progress to more severe conditions such as pyelonephritis that do require hospital admission. 90% of uncomplicated urinary tract infections are diagnosed just based on the common symptoms such as frequency, pain, dysuria. So that's a fairly standard approach to how those conditions are looked at. And treatment can involve just symptomatic treatment, so analgesics for the pain, some other, drinking lots of water and other options as well. But what we also know is that a short course of prescription antibiotics, so required from a medical practitioner, can also rapidly reduce those symptoms and the duration and the rate of complications for women affected by UTI. Some information about UTI and our hospital system as well. So this slide presents data that come from our ED admissions in South Australia from 2021 to 22 for kidney infections and UTIs, where you can see in the low acuity band of UTIs, we've had 43% of those of the total, and 57% have been much higher acuity, with a total of round about 9,000 presentations to ED in 21-22. On the right-hand side, what I've got there is some work that was done by the Australian Commission on Safety and Quality in Healthcare a little while ago now, about potentially preventable admissions, and finding that urinary tract and kidney infections are in the top 12% in South Australia for potentially preventable admissions. Just to be clear what that is, so a PPA is a proxy measure of primary care effectiveness. So conditions that could theoretically be avoided if managed in a timely and adequate sense, usually before arriving at hospital. So things like vaccination, a lot of acute conditions and some chronic conditions fall into those. So yeah, as I said, for South Australia, it's a reasonable high number then. 12% of all of our preventable admissions to hospital come from this group of conditions. And I have included there, just for completeness and just so we remind ourselves, that we've got higher rates of hospitalisation for our Aboriginal and Torres Strait Islander population, about 2.2 times in this category. Also, patients that come from lower socioeconomic areas and remote areas fall into that group where there's higher rates of hospitalisation as well. So UTI, and particularly these lower acuity ones, have been a target across the country for people to try and look at how can we reduce those and prevent those admissions where possible. In particular, I'll just reflect on Queensland community pharmacy pilot that was commenced in June 2020 and finished in April 2022, where 800 pharmacies in community, 2,000 pharmacists working in them, participated in the pilot and looked after just over 10,000 instances of services of women coming in, presenting with symptoms of a UTI, being assessed by the pharmacist as to whether or not they did actually potentially have a UTI or something else. And where that was appropriate to treat, the pharmacist could supply one short course of antibiotics. Particularly looking here, we've excluded people that may have had multiple conditions, maybe higher risk, for example, older patients or patients with diabetes. And so what the key findings of that study that were reported in September that year as well was a very good outcome for consumers. that they did experience value from the service. It was accessible and convenient and timely for them. And they did have resolution of their symptoms in a high percentage of the cases, which was aligned with what we'd expect through treatment in other settings as well. It was reported that pharmacists were able to deliver the care safely and appropriately, aligned with the clinical protocols that applied. And of course, that pharmacists, with some additional skills and training, could manage the empiric treatment of uncomplicated UTIs in that setting. So in South Australia, we had a select committee, so a parliamentary committee was convened to actually look into barriers facing sufferers of UTI in gaining timely access to treatment. This was convened in December 2022 under the chairmanship of Ms. Jane Stinson, who's the member for BADCO. And it was a bipartisan group. So in addition to looking at understanding how consumers were finding access to UTI treatment, the committee were charged to look at whether the Queensland model was something that could be useful to look at in South Australia as well. It was quite a big select committee, so they had 151 submissions received. About 33% of those were from consumers themselves. Others were from medical practitioners, pharmacists, universities, peak organisations, as well as our local South Australian advisory group on antimicrobial resistance also presented a submission. And they had 24 hearings, both here in South Australia and in Queensland, visited sites up in Queensland to gain their experience as well. So that select committee, which is known here as the Scooty, really found, I guess, exactly what Queensland was showing as well, that consumers were experiencing delays in accessing treatment and advice for urinary tract infections, that they did then end up having long waits either in EDs or other treatment settings to be seen. And they were reporting that it did have a significant impact on them as a person and also on their work and family lives. The committee also looked then at whether there was support for the Queensland type of model, and as you can see here, 80% of the submissions were broadly supportive of that kind of a model being implemented. So the committee had 29 recommendations in their final report in 2023, and there was unanimous support across the parties that were involved in that group with those recommendations. Just to flag up as well, that committee also looked at the overseas experience with community pharmacies in Canada, UK, US and New Zealand, also providing a range of different access to different treatments for different conditions, including UTIs, had been successful, and some had been in place for many years. In addition to that, we know that New South Wales also set up a clinical trial, a very detailed clinical trial, which in fact South Australia was planning to participate in, but that didn't progress. And a number of other states and territories also had pilots in place at the time. So lots of work going on in that space. So the government response was that it did endorse all the recommendations of the select committee, and that was primarily to implement a pharmacy UTI service with the date of March 2024 for it to be implemented with monitoring and then an evaluation of uptake within 2 years post that time. The committee recommended and the government supported that implementation and approach should be evidence-based and closely aligned with the other state and territories, in particular Queensland, from a perspective of consistency and equity of access. Just to highlight here, our government did look to see that there'd been a number of pilots and a number of evaluations and felt that South Australia should implement a program based on those rather than, I guess, reinventing the wheel, assuming that South Australian consumers are pretty similar to consumers in other states. But obviously it was important for us to work through local aspects, and that was our next steps as well. I just highlight that they did have 29 recommendations. Only 2 of them were not related to UTI, so there was a lot of detailed recommendations. The other 2 were that oral contraceptive resupply should also be implemented by May 2024, so a pharmacy-based program to support women who are needing ongoing supply of contraception, and to investigate further scope expansion, which we're in the middle of at the moment. So from there, I guess it was handed over to me to set up a process and a project to implement a community pharmacy service for UTI here in South Australia. And that commenced in around October 2024, with those aims of promoting consumer choice and access to care, increased timeliness of that care, and hopefully to look at whether or not these services then reduce hospital ED pressure and reduce some pressure on the primary care setting as well, by providing that additional choice for consumers, in particular in areas where perhaps they couldn't get into a GP, where different hours were applicable, etc. So it's just another option. And I've just highlighted recommendation 1 of the committee there, which is where we started. Was in effect what this meant was that antibiotic medication could be used to treat urinary tract infections from pharmacists under that model similar to Queensland, with a restriction of women aged 18 to 65 years of age who were deemed to be likely suffering from an uncomplicated UTI after assessment by the pharmacist, and assessed by the pharmacist as at low risk of complications. So a very an advisory assessment process linked then to the ability for a pharmacist to give what was usually required on prescription, a short course of antibiotics. Included in this as well, and we'll go through a little bit more detail, was that patients who didn't fit those criteria could come to a pharmacy but would then need to be referred on, particularly where there was potentially more serious symptoms. Obviously complementary to those other services available, so good communication with GPs as well was a key part of what we were looking to achieve. My next slide is kind of a jigsaw puzzle, when I guess many of you would have implemented projects, small or large in scale, where there's lots of different project scoping and planning and many different aspects that need to be addressed. And we did have a pretty short time frame to address these. So just the main thing was really scoping out and initiating the project plan, looking at what management protocols might be developed and how they might be developed, what training would be required, what software was available and what might be required. We did need to undertake a regulation amendment to our controlled substances regulations to enable pharmacists to actually issue a prescription medicine legally. And then aspects around the communications, promotion and monitoring and evaluation. So lots of different aspects there. And I guess what we did with that was really use project software and a really good project team to try and bring that together and keep it on track for the couple of months we had to implement that. So the first step was to look at the governance, and we did have a pretty high level governance. So we were reporting to the minister in this case through SA Health Chief Exec, with myself as the executive sponsor. We formed a project board, which was a pretty important group. We had a number of departmental executives, the chair of our statewide medicines advisory committee, who's a clinician, a chief medical officer, and a number of our team contributing to that board. And you can see on the right-hand side, it's my one, it's on my right. We also formed an implementation advisory group. So that's that key stakeholder engagement piece, which has been central to how we've done everything as we've moved along with this, and obviously very critical to have that input and support and expertise to us. That group did include, the slide here, I think, a range of experts and representative groups. So GPs, pharmacists and pharmacy organisations. We had infectious diseases and renal specialists on the group. Importantly, our consumer voice was always been important to these projects, and we had a couple of consumers participate in the group. We also had our regulatory authority contribute, and Aboriginal Health were also invited to that advisory group. This slide also just highlights, regional and rural pharmacists were also included on that group. Also highlighting, a range of others that we had to collaborate and consult with over time, including our training providers and our pharmacy software providers and medical software providers. And we did continue to work with other jurisdictions as well to keep ahead of the curve and learn from their learnings as we went along. So the steps that we took, I'm just going to run through a little bit of detail here, were to set up a management protocol which outlines what pharmacists could and couldn't do and how they might manage the program as we went forward. It was based on existing professional standards and, importantly, national and local therapeutic guidelines. So those nationally agreed therapeutic guidelines are now SA UTI empirical treatment guidelines. That's a guideline set up for our clinical implementation across the public sector here. We also use the Australian Medicines Handbook as that key reference as well around medicines information. So the actual protocol itself was very detailed. I won't go through everything that was included here, but you can see the list there. It's really a lot of conditions around what pharmacist training should be, registration of the pharmacy, what was in the pharmacy, which medicines were included. Importantly, that patient eligibility and referral criteria, clinical documentation, information about how pharmacists may or may not charge fees for the services they provided, and then a clinical flow chart as well to guide some of that decision making was developed. And just to highlight again, so the empiric treatment was based on national guidelines with local expert input and around particularly what antibiotics and what our sensitivity data show here in South Australia. And at the time it was very similar to the national recommendations, so that's what we stayed with. That it is around the common symptoms, so 90% of women being able to be diagnosed if they have that range of common symptoms and no other factors that may need to be exclude them. So looking at low risk women only in that age group, as we said, 18 to 65 with a symptom assessment, excluding people that were pregnant, had recurrent UTIs or had other indications that may indicate they may have more susceptibility or risk by having a UTI. And then building in the referral process and red flags where anything was uncertain to another medical practitioner, or another health service, which did help to pick up, and we hoped it would and did, when patients really needed to get seen much more quickly than they might have normally based on their symptoms. So, as I said, the flowchart was put together, and that was really to guide the clinical decision making and make sure people are aware of those key points of referral. Things like that don't cover every circumstance. Pharmacists were required to exercise their professional judgment and their knowledge and work with individuals in deciding that at an individual level what was the best process and care pathway. And as I said, it was adapted from the national work with input from our local key stakeholders to make sure it was addressing South Australian referral pathways, for example, as well. I've just got that flow chart there. You probably can't read it, but you can see that that's the start of a person coming in. Do they fit the age and the female demographic? Discussing with the patient in a private area what were their symptoms, etc., and working through with referral paths off to the right. For example, we can see this one on the, are there any symptoms of pyelonephritis or systemic symptoms in the red, so it's colour coded, with immediate referral to an appropriate treatment consultation. Others where the pharmacist could commence treatment, offering up also other kind of supportive care as well, and then referring to a GP or health service if symptoms did not resolve within a couple of days. This is in the red box here showing patients that were going to be excluded. There's quite a long list, so any of the concerns that were listed here would mean the person would actually be referred for immediate appropriate follow-up rather than being managed in the pharmacy. So really trying to focus in where pharmacists have been trained and where this is a more straightforward approach that can be commenced, again, still being followed up if the patient hasn't had a response within a short period of time, which is what would be expected. In addition to the guideline, we also put into the protocol the documentation that pharmacists needed to follow, which is obviously very similar to what a medical documentation would look like. That's a comprehensive clinical record. They had to, any medicines that were dispensed had to be included in the dispensing system, and also in My Health record. Medicines dispensed can be recorded there and are recorded there so that other health practitioners can see that, and obviously the consumer themselves can see what's in their own My Health record. We did have some discussion from consumers that indicated that not all consumers may have a My Health record, and some also may not wish everything to be loaded up. So there's some conversation to be had around consumer consent in that space as well. And following on from that was also the communication and shared care aspects that were also really well discussed between our GPs, pharmacists and other specialists on the advisory committee, that trying to build up these integrated models and making sure that the treating medical practitioner or the usual medical practitioner is aware of, with the patient consent, what's been happening outside of their usual consultation in that practice. So what pharmacists have been reviewing and what information they've provided was also asked to be shared. Approved training, as I mentioned, luckily for us, there was already approved training available from 2 different training bodies, accredited training providers. We did, having said that, go through the training that was provided and made sure it was relevant to South Australia, and also that those training providers were particularly reflecting our protocols and our legislation, for example, which would be slightly different to what was in interstate. At the time, it was quite fortuitous because the pharmacists in South Australia had free access to at least one of the training programs for about the first 12 months. And the second one, that you see, the Pharmaceutical Society of Australia, was also free if they were a member, and a couple of $100 training cost for non-members. So it was quite accessible to pharmacists, and you can see what sorts of information was included there to upskill pharmacists. They're already trained on all the aspects of UTI and treatment and management of UTIs in their undergraduate courses, but this was to supplement that, and particularly focusing in on a differential diagnosis to support them stepping into this slightly expanded role. I just wanted to mention antimicrobial stewardship. So that was a very important aspect of what we considered as well. So we know that that's antimicrobial resistance is a key challenge around the world, coming from probably overuse of antimicrobials. And we did work with our infectious diseases and microbiologists to make sure that this program did not contribute further and that we could continue to monitor that. And I'll talk a little bit more about that later on with the outcomes. But some of the aspects we were looking at were to make sure that prevention and supportive care are also discussed and supported with patients, to follow those evidence-based clinical flowcharts, which are the national recommendations for antibiotics. And including that, we've excluded patients who are at risk of developing resistance by frequent use of antibiotics or more recent use of antibiotics as well as patient counselling on the appropriate use and recording information into the dispensing software. And you can see we've got a referral document there as well, the antimicrobial stewardship document from the Australian Quality and Safety Commission. So a range of resources were produced and they've all been put up onto the website. This is obviously another area where we worked really closely, getting input from our consumers, our advisory groups, so that we had these fact sheets available and information available in the language and addressing the concerns or addressing what needs to be known by each of those different groups. So we did implement from March, we made the implementation date of March the 1st, 2024. And from that time on, pharmacists had been undertaking, the training was made available earlier so that people could start to offer the services from the date that we were able to have it legally enabled. And I'll just go through a couple of slides now about results. So this slide shows the uptake of services in the first 3, 6 and 12 months of the service. And you can see that there's been a very good uptake by consumers. So 2,000 in the first 3 months, up to 7,200 consultations in the first 12 months. And as of, I think it's last month, we've got now 12,000 women who've had a service provided through community pharmacy for urinary tract infection symptoms and assessment. Equally, we were really impressed with how quickly the pharmacists took up the training. So we've got about 2,500 pharmacists in South Australia. So nearly half of them were trained within the first 3 months. And we continue to see a small increase over time in that space as well. So not everyone's doing it, but certainly getting up around the 75% of pharmacists now. This slide showing a map of Australia with the postcode of the patient who's had a service. We know that we've as well got 362 of our pharmacies across South Australia have provided a service. And you can see from this that most of them are in South Australia, but certainly we've had some people travelling, coming from interstate on travels that have also managed to access the service while they've been travelling. We have got some data, and I've just pulled a few things out to show here today about how it's working. And so, for example, looking at protocol adherence, we can see that these symptoms that we've been looking for pharmacists to work with have been closely followed, with most patients having 1, 2, should have at least 2, if not 3 of the symptoms that are listed, and that has been occurring. We can see that the choice of antibiotic as our first line treatment was the drug called trimethoprim, which is a 3-day course of antibiotics, and 93% or 94% of patients that received an antibiotic were given that first choice. We've got other options there, and sometimes that's because a person might have an allergy to trimethoprim, they might have a previous resistance, it might not be available. So having different options, but minimal use of those. And particularly cefalexin, which we know is our third line because it's a much broader spectrum antibiotic and more likely to be associated with resistance as well. And again, these are the results that we're working with our ID and micro medical practitioners to review. We did see a small number of cases that were recorded as not having a treatment in the pharmacy and being referred to other medical practitioners for assessment, and mainly that was based on symptoms in the blue section. Current UTIs were 14%, and the medical history indicating, I think it's 28%, that perhaps this person really should be followed up more closely as well. So this data is from our metropolitan hospital emergency departments and shows the rate of admissions for urinary tract infections in the age group that we're looking at in women over the period from 2020 to 2025 now. And you can see the blue chart back 2021, 2022 shows kind of up and down, but a very, very slight increase. And then in the green section is from March 2024, a pretty significant drop in ED presentations for people that were eligible to be treated in the community pharmacy program, which is about a 27% drop now. Started with about a 20% drop and it's continued to grow down with uptake, so around 27%. We don't know if this is all attributable to pharmacy, but we are starting to look at a little bit more detail and breaking this data down further as well to answer some more questions as we go along, but certainly that trend is quite significant. From a safety perspective, we had a system where people could report and also speak to their pharmacist, but also report via the website if there were any concerns. The usual pathways of reporting practitioner behaviour were available, and we haven't had any reports to date into any of those pathways, and that's consistent with the Queensland and New South Wales clinical trials and pilots, that there have been no serious safety signals coming, which is good. And just that bottom dot point, that now all states and territories, including us obviously, have adopted these services into routine practice. So just to finish off, we did experience lots of barriers and challenges in taking this forward, the usual things around timeframes and resources. That innovation and practice change is hard. And there's many interdependencies. We had time for the regulation amendments to go through and a range of other challenges that we're continuing to probably work through, probably around the fact that this was something quite new, that consumers do have to pay for the treatment. It's not covered by the PBS and it's not covered by the MBS either. My health record reporting for clinical information is really only there for medical practitioners to upload at the moment, so other practitioners can't necessarily upload clinical data other than the medicines into that system at the moment. As far as software goes, we know that the pharmacy software was really helpful for documenting and recording the treatments and the consultations, not just the treatment. But then there were still some things that we thought could be done better. For example, patient follow-up and connectivity with medical software as well is something that's come up. The enablers that we had were really having an excellent project team and with project management skills, and we did use the My Projects database that's available through SA Health. And whilst that was quite a challenge to set up at the beginning, it was an absolute must for us to keep on track of what were our timeframes, what were our tasks, who was doing them, and trying to make reports from that as well, so dashboards and things like that. We did continue to reflect that early and ongoing engagement with key stakeholders and is absolutely vital in whatever we're doing. And we have got some really good collaborative relationships built through this work. And a number of other things, in particular the consumers were very important to have, and important to have that consumer voice continually bringing us back to why are we doing what we're doing and who is this about. Very important. And obviously not reinventing the wheel, so national, state, international learnings, making sure that we build in that local assessment, but having a pretty high barrier to really why should we change things when they've been well established elsewhere? Only the really key things should be changed. So we're continuing to evaluate this. We've already done the first 12 months and looking now at the next 12-month period. We're coming up to that in March, April next year, which is continue to be good. We want to drill down a little bit more about people with concession and non-concession cards and whether they're accessing what's happening in regional Aboriginal communities as well. And as of next year, we'll have, it looks like some ongoing embedded longitudinal work that we're going to be able to use students, pharmacy students in community pharmacy to assist with. We have continued to monitor the antibiotic patterns and resistance, and we've just done a review with the micro team, Dr. Morgan Warner, who's been fantastic in this space with us. And what we know is there have been an update to the national guidelines based on national resistance patterns. And it's been valuable to have Morgan's input into that to look at what are our resistance patterns and to give us advice around that and whether or not we need to change. At the moment, we can report that there have been no changes in resistance patterns in South Australia over this particular period of time. Raising those data linkage and integration aspects is what we're continuing to do nationally as we see more uptake of broader scope of practice across more professions and obviously learning. So just to finish off, just putting this up just to remind us again, patient-centred care and looking at the health system and our national context, that we really can make some important changes and accessibility and choice for consumers. Building in the collaboration and integrated models is going to continue, I think, and we have some learnings from this that we're applying to new work now. We have increased job satisfaction, so the pharmacists have found it really great to be able to offer more care to their patients instead of having to tell them late at night, you have to go to an ED, I can't help you. And really getting much more of their clinical knowledge and expertise and competency used. And of course, we're starting to see hopefully some reducing demand by having this additional workforce available. So I'll finish off there. Just say thank you again for the opportunity and happy to take questions.
Thanks, Naomi. That's wonderful.